tide came and brought you in, and I could go on and on and on, and I will. Skies grew darker, currents swept you out again, and you were just gone and gone, gone and gone. In silent screams, in wildest dreams, I never dreamed of this. This love is good, this love is bad, this love is alive back from the dead. Oh, these hands that to let it go free, and this love came back to me. Oh, oh, oh. Tossing, turning, struggled through the night with someone new. And I could go on and on and on. Lantern burning, flickered in my mind. Only you, but you were still gone, gone, gone. In losing grip on sinking ships, you showed up just in time. This love is good, this love is bad, this love is alive back from the dead. Oh, these hands had to let it go free, and this love came back to me. Oh, this love left a permanent mark. This love is glowing in the dark. Oh, these hands had to let it go free, and this love came back to me. Your kiss, my cheek, I watched you leave. Your smile, my ghost, I fell to my knees. When you're young, you just run, but you come back to what you need. This love is good, this love is bad, this love is alive back from the dead. Oh, these hands had to let it go free, and this love came back to me. Oh, this love left a permanent mark. This love is glowing in the dark. Oh, these hands had to let it go free, and this love came back to me. Oh, wise men say only fools rush in, but I can't help falling in love with you. Oh, shall I stay? Would it be a sin? Oh, if I can't help falling in love with you. Like a river flows surely to the sea, darling, so it goes. you. Oh, for I can't help falling in love with you.
Everybody loves the things you do, from the way you talk to the way you move. Everybody here is watching you, 'cause you feel like home. You're like a dream come true. But if by chance you're here alone, can I have a moment before I go? 'Cause I've been by myself all night long, hoping you're someone I used to know. You look like a movie, you sound like a song. My God, this reminds me of when we were young. Let me photograph you in this light, in case it is the last time that we might be exactly like we were before we realized we're scared of getting old and made us restless. It was just like a movie, it was just like a song. I was so scared to face my fears. Nobody told me that you'd be here. And I swear you moved overseas. That's what you said when you left me. You still look like a movie, you still sound like a song. My God, this reminds me of when we were young. Let me photograph you in this light, in case it is the last time that we might be exactly like we were before we realized we were sad of getting old and made us restless. It was just like a movie, it was just like a song. When we were young, when we were young, when we were young, when we were young. It's hard to admit that everything just takes me back to when you were there, to when you were there. And a part of me keeps holding on, just in case it hasn't gone. 'Cause I still care. Do you still care? It was just like a movie, it was just like a song. My God, this reminds me of when we were young. Let me photograph you in this light, in case it is the last time that we might be exactly like we were before we realized we were sad of getting old and made us restless. Oh, I'm so mad I'm getting old, that makes me reckless. It was just like a movie, it was just like a song. home when we were young.
So it's probably nothing, but it's been on my mind sometime and I can't let it go. I know there's gotta be something that I could say in time, but I can't find the words. Keep me on fire. Keep me on fire. A dose, a moment to live in, and I'm hoping it stays a while in this space you were in. And I froze, and I reckon I missed it, when all of the rain came down in the shape of everything. So keep me on fire. Keep me on fire. Keep me honest, keep me kind, keep me as your finish line. Keep me on fire.
Hand fits in mine like it's made just for me. But bear this in mind, it was meant to be. And I'm joining up the dots with the freckles on your cheeks, and it all makes sense to me. I know you've never loved the crinkles by your eyes when you smile. You've never loved your stomach or your thighs, the dimples in your back at the bottom of your spine. But I'll love them endlessly. I won't let these little things slip out of my mouth. But if I do, it's you, oh it's you they add up to. I'm in love with you. And all these little things.
You can't go to bed without a cup of tea, and maybe that's the reason that you talk in your sleep. And all those conversations are the secrets that I keep, though it makes no sense to me.
I know you never loved the sound of your voice on tape. You never want to know how much you weigh. You still have to squeeze into your jeans, but you're perfect to me. I won't let these little things slip out of my mouth. But if it's true, it's you. It's you, they add up to I'm in love with you. And all these little things, you'll never love yourself half as much as I love you. And you'll never treat yourself right, darling, but I don't want you to. If I let you know I'm here for you, maybe you love yourself like I love you. Oh, and I've just didn't know I was lost. I didn't know I was lost. I didn't know. Just a young gun with a quick fuse. I was uptight, wanna let loose. I was dreaming of bigger things and wanna leave my old life behind. Not a yes sir, not a follower. Fit the box, fit the mold, have a seat in the foyer. Take a number. I was lightning before the thunder.
Thunder, 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 thunder,
Thunder, feel the thunder. Lightning and the thunder. Thunder, feel the thunder. Lightning and the thunder. Thunder, thunder, thunder. Kids were laughing while I was scheming for the masses. Who do you think you are? Dreaming about being a big star. They say you're basic, they say you're easy. You're always riding in the backseat. Now I'm smiling from the stage while you were clapping in the nosebleeds.
thunder, 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 thunder,
Thunder, feel the thunder. Lightning and the thunder. Thunder, feel the thunder. Lightning and the thunder. Thunder.
thunder, feel the thunder. Lightning and the thunder, 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 feel the thunder. Lightning and the thunder, 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 feel the thunder. Lightning and the thunder, 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 feel the thunder. Lightning and the thunder, 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 feel the thunder. Lightning and the thunder, thunder.
Freezes just like ice, and there's a cold and lonely light that shines from you. You wind up like the wreck you hide behind that mask you use. And did you think this fool could never win? Well, look at me, I'm coming back again. I got a taste of love in a simple way, and if you need to know while I'm still standing, you just fade away. Don't you know I'm still standing better than I ever did, looking like a true survivor, feeling like a little kid. And I'm still standing after all this time, picking up the pieces of my life without you on my mind. I'm still standing. Yeah, yeah, yeah. I'm still standing. Yeah, yeah, yeah. Once I never could have hoped to win. You're starting down the road and leaving me again. The threats you made were meant to cut me down, and if our love was just a circus, you'd be a clown by now. No, I'm still standing better than I ever did, looking like a true survivor, feeling like a little kid. I'm still standing after all this time, picking up the pieces of my life without you on my mind. I'm still standing.
I still remember 3rd of December, me in your sweater. You said it looked better on me than it did you. Only if you knew how much I liked you. But I watch your eyes as she walks by. What a sight for sore eyes, brighter than the blue sky. She's got you mesmerized while I die. Why would you ever kiss me? I'm not even half as pretty. You gave her your sweater, it's just polyester, but you like her better. Wish I were Heather. Watch as she stands with her holding your hand, put your arm round her shoulder. Now I'm getting colder, but how could I hate her? She's such an angel, but then again kinda wish she were dead as she walks by. What a sight for sore eyes, brighter than a blue sky. She's got you
mesmerized while I die. Why would you ever kiss me? I'm not even half as pretty. You gave her your sweater, it's just polyester, but you like her better.
Good morning, Amna, Dr. Mazeh.
Good morning. Can you hear me well?
Yes, I can hear you well.
Hi.
Hi, how are
Good
you?
morning. I know it's early for you.
Yeah, it's still like almost 9, but it's okay.
Oh, that's fine.
Yeah.
That's not bad.
So how are you?
I'm good. I'm good. How are you?
I'm good, thank you. So we might start like 5 minutes more. So if that's okay for you.
Absolutely. So start in 5 minutes. Yeah.
Yeah, thank you very much.
Yeah, no worries.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone, and good morning and good afternoon for those who are in Melbourne. Welcome to our second series of international guest lecture. My name is Alia, and I will be your MC for today's event. I would also like to welcome our honorable speaker for today, Dr. Amna Mazeh from University of Melbourne. It's a pleasure to have you joining us today. Ladies and gentlemen, we kindly ask all participants in today's Zoom room to turn on the camera for a virtual photo session. We're going to start from page 1. Okay, thank you. Next to page 2. Thank you. Ladies and gentlemen, without further ado, we will continue to our main event, which will be moderated by Dr. Dionisa. To Dr. Dionisa, the time is yours.
Thank you, Alia. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Before we are moving to the main event, I would like to welcome Dr. Amna Mazeh. Thank you for joining us today. And I would like to introduce first Dr. Amna Mazeh, our wonderful speaker today. So, yes. So Dr. Amna Mazeh is a lecturer at University of Melbourne, Australia. She graduated from Uppsala University, Sweden, for Master of Science in Pharmacy, and finished her PhD at University of Melbourne with the topic, the comparative cardiovascular and non-cardiovascular actions of cannabidiol, an important cannabis therapeutic agents. During her career, Dr. Amna had worked as a dose dispatch operator and pharmacist, and then began her career as a lecturer since 2017 until now. Dr. Amna Mazeh has received various awards, among them Uppsala University Scholarship, Melbourne Research Scholarship, and AppCam Prize as a winner of the oral presentation at the Faculty of Medicine, Dentistry, and Health Science Early Career Research Network Symposium 2020. Also, Dr. Amna has published several articles. Among them are Pharmacological Characterization of the CBI receptors antagonist activity of cannabidiol in the rat phase difference bioassay. Cannabidiol selectivity inhibits the contraction of rat small resistance, and many more. So today, Dr. Amna will talk about the understanding of pharmacokinetic and pharmacodynamics of drug-drug interactions. So without further ado, let's welcome her. And to Dr. Mazeh, the time is yours.
Thank you so much. I want to start off by saying, I think you say Selamat Pagi. Is that good morning?
Yes, that's right.
I'll just share and you can tell me, can you see the presentation as a full screen?
Yes, we can see it clearly. Perfect.
And I want to say, before I get started, I would love for this to be interactive. Please use the chat function if you have any questions, because I will ask some questions, and I tend to think that it's the best way of learning about a topic. So thank you for that beautiful introduction where you did go through a little bit of my journey. You may be able to hear in my accent that I am not Australian, but I am on Australian land. So I want to start by the acknowledgement to country. So I want to begin today by acknowledging the Wurundjeri people, the traditional custodians of the land on which I am located at today. And I want to pay my respects to the elders past and present. And I extend that respect to Aboriginal and Torres Strait Islander people here today. So a little bit about my journey, because yeah, as I mentioned, I'm not from Australia. I'm originally from Sweden, where I studied at Uppsala University to get my Master of Science in Pharmacy degree in 2016. So I am a pharmacist as a background. And then I did go for an exchange in University of South Florida in the USA. That was followed by my master's degree project at Harvard, which then inspired me to do a PhD in Melbourne in the Department of Pharmacology and Therapeutics, which is now Department of Biochemistry and Pharmacology. And I am now a pharmacology lecturer, and mainly focusing on pharmacodynamics, but also pain and so on. So I will get started with today's topic, which will be on the drug interactions from a more of a perspective of pharmacodynamics and pharmacokinetics. And please correct me if I'm wrong, but I think all of you have had some kind of pharmacology to different various degrees. So excuse me if I over-explain something. I think it's better to do that than do the opposite. So let's get started with this, I guess, quite interesting and fascinating topic about drug interactions. So the definition of drug interaction is that it occurs when a patient's response to a drug is modified. And that can happen, for instance, when you're using food. It can be nutritional supplements. It can be formulation excipients. And with excipients, what that means is that when you have a tablet, it will have the active substance. So we'll have paracetamol, ibuprofen, but it will also have the filling substance like lactose and other compounds that sometimes can interact with drugs as well. But with drug interactions, you can also have that with other drugs, but also diseases. And the main focus will be drug interactions, or drug-drug interactions. And I hope I can convince you today that while they are mostly harmful, at times they can also be beneficial. So I mentioned that drug can interact with food, supplement, drug, disease, and even laboratory tests. It's actually quite common that when blood tests are being done on patients and they are on a particular drug, it may skew the result of the lab because there may be some drug lab interactions, but we'll just focus today on the drug-drug. If I can please ask you to use the link up here, it's called polev.com/drug interaction, and just answer this question. I'll wait a little bit. What do you think are the consequences of drug interactions? So just click on that link and write down whatever you think may be the consequences of it. And it can be anything that springs to mind. And please let me know if it's not working.
It's not working. Can you share the link again, maybe?
Oh, okay. So it's, yes, so it's Paul. I'll just write it down in the chat. polev.com/drug interaction. Try that. So it's the link up here. And it's fine if it's not working. I do have the answers for you. It's not you giving the lecture. I'll give it a minute or so. Sedation, beautiful answer. Sedation absolutely happens, especially when you're dealing with drugs that absorbs through the brain or cross the blood-brain barrier, and alcohol. Great answer, and a very common interaction. That's why it's very often advised that you should not be driving while on some medication. I'll just jump to the actual answer of this question. Let's see. Oh, addiction tolerance. That's not usually drug interaction, less efficacy of a drug. Absolutely. Less effective, less efficient. That's one of the main issues. So let's discuss these issues as well. So I did mention, and some of you did mention, that they produce adverse effects. Absolutely. But sometimes also beneficial effects. And the problem with a lot of these adverse effects associated with interactions, or even adverse effects that are not associated with interactions, we don't know a lot about them. We don't know the exact percentage and so on. And the reason is that there is an inefficiency of self-reporting. A lot of patients, when they experience these adverse effects, do not report it. And there's also issues with the system in self-reporting that causes patients to not do that. And I can mention that adverse effects are 12% of the causes to hospitalization. That's quite a high number, and this is worldwide, that a patient would come to the hospital not because they broke their leg or there's a just cardiovascular disease, it's because they have an adverse effect because of drugs. So it's not a small issue. And out of these 12% adverse effect cases, 5 to 20% are due to drug interactions. And then out of the 12%, out of the 30% that leads to death or fatal adverse effects, they are also due to drug interactions. So I hope I've convinced you that this is quite of a serious issue. And it does origin from our lack of knowledge, but also lack of surveillance of patient drugs treatments. And there has been shown that the greater risk of drug interactions are observed in drugs that have high or severe toxicities, but also with drugs with narrow therapeutic index. Are you familiar with the therapeutic index? And yeah, I see some noddings. Therapeutic index deals with the fact that the concentration for a drug to be effective is very close to the concentration in which it's toxic. And whenever you're dealing with drugs like that, it's very easy that whenever you do change the concentration through interaction, it may lead to toxicity. However, we do know that drug interactions are more likely to be detected if we're dealing with a drug that is monitored. So for instance, we have warfarin that is used as a blood thinner. Patients on warfarin are very well monitored for their drug concentrations. And because of that, it's more likely that we do discover any kind of interactions. So maybe that is a solution, but it's also very expensive to keep monitoring patient blood serum levels. And there is an increased probability of drug interaction in older patients. You can imagine as we all age, we will have more comorbidities. And as we have more comorbidities, we need a greater amount of drugs to be treated with. So on average, a 65-year-old will have around 5 medications, and therefore increasing the likelihood of interactions. So now let's talk about the drug and drug interactions. I'm not going to talk a lot about food, supplement, disease, or laboratory, but drug-to-drug interactions. They can have 2 different branches. We talk about pharmacodynamic drug-to-drug interactions, but also pharmacokinetic. Pharmacodynamic drug-to-drug interactions, it deals with interactions that will affect what the drug does to the body. And you all would probably know this by now, but pharmacodynamic is what drug does to the body. And pharmacokinetic deals with what the body does to the drug. How does the drug get broken down in the body? How does it get absorbed? How does it get distributed, and so on? And the way we define pharmacodynamic drug-to-drug interactions is that when drugs are added together, they may have an additive effect or opposing effect. In some cases, you'll have 2 drugs that will cancel each other out. So the patient won't have any of the benefits. And then we have pharmacokinetics drug-to-drug interactions, which deals with when a drug changes the concentration of another drug, and that leads to an altered concentration in the body, but can also lead to an altered time of exposure. So in pharmacokinetics, we get a steady state concentration, or we have a Tmax, the time in which the drug reaches its maximum concentration. That could be altered with pharmacokinetic drug-to-drug interactions. And then there's a further division. So from pharmacodynamic interactions, we have receptor-mediated, cellular, functional, and with pharmacokinetic, we have ADME, absorption, distribution, metabolism, and excretion mediated. So with pharmacodynamic, we'll be discussing a few because it's not the biggest group of interactions. They are mainly pharmacokinetic, but we'll discuss both of them separately. So let's start with pharmacodynamic interactions. So pharmacodynamic interactions could be intentional. So with patients with hypertension, it's not often that you see a patient, especially an older patient, that is only treated with one antihypertensive drug. So usually with patients with high blood pressure, we use different drugs at the same time. And I hope you're thinking, oh, why don't we just use maybe one drug and have a really high concentration of that? And I hope that makes you think that, oh, whenever we increase a dose of a drug, we do have an increased risk of adverse effects because we have an increased risk of off targets. So one way to overcome that is by combining different antihypertensive drugs that have different targets. And that way you can keep the doses at concentrations or doses that are low enough where you don't get adverse effects, but you get the benefits. So that's one example of where we actually use these interactions for the purpose of benefiting a patient. But there's also unintentional, which is most of them, unfortunately. For instance, we have serotonin syndrome that can be a result from combining tramadol. Tramadol is an opioid used to treat moderate to severe pain, usually around moderate pain. And when that's combined with SSRI, selective serotonin reuptake inhibitors, and just to remind you, SSRIs are used to treat anxiety, depression, The mechanism of action is to inhibit the reuptake of serotonin to the neuron. So you get more serotonin in the synapse. More serotonin in the synapse more means that you get more activity of serotonin receptors, and therefore you stabilize the deficiency or the decrease in serotonin that a person may have. But the combination of those can cause serotonin syndrome, which can be quite severe. It can cause shivering, diarrhea, muscle rigidity, and a lot of different issues. So this would be unintentional. But you can see that this combination wouldn't be too unlikely for patients to get both. So it does happen. And I did mention that we have beneficial and harmful interactions, pharmacodynamic interactions. And I will tell you that throughout this webinar, I will be giving you a lot of different examples. So you'll have to brush up on your pharmacological knowledge about some of the most typical drugs. But I'll try to explain the pharmacodynamics of them or their mechanism of action. So it's not just name dropping drugs. One example where these pharmacodynamic interactions are beneficial is in the treatment of asthma. So a patient with asthma will come in and they usually will get a long-acting beta-2 adrenoceptor agonist. But very often they also get corticosteroids in addition to that. And the benefits of that is not only that corticosteroids have anti-inflammatory effects, but very fascinating, corticosteroids also upregulate the number of beta-2 adrenoceptor receptors. So what that means is the patient who is getting the beta-2 adrenoceptor agonist are now having also more receptors expressed. And if you have more receptors expressed, then it's more likely for that agonist that they're getting to bind to that receptor and have that bronchodilation. So it actually enhances the effect of beta adrenoceptors. So not only does it upregulate the number of beta-2 adrenoceptors, it also improves the binding affinity of the beta agonist. So you can see how now suddenly the same dose of the beta-2 agonist is having a greater efficacy in the patient. So that's one way where pharmacodynamic drug interactions are highly beneficial. And then harmful, we can use asthma again. And this is something that does happen sometimes where a patient in asthma, and just to remind you, so beta receptors, there are different subtypes. We have beta-1, beta-2, also some other beta that have come up in recent years. Beta-2 are expressed in the lungs. When we agonize them with an agonist, they cause a dilation of the bronchs, making it easy to breathe. But an agonist of beta-1 in the heart will cause an increase in heart rate and in the contraction of the heart, so increased blood pressure. So in patients with hypertension, one way of treating them is by using beta blockers. So for instance, this propranolol. Propranolol is a beta-1 and beta-2 antagonist. So imagine if a patient is hypertensive and they're getting treated with propranolol, a beta-1 and beta-2 antagonist, then the beta-2 aspect of the antagonism will also block the beta-2 receptors in the lungs, meaning that instead of getting dilation, you get constriction of the lungs. So that's one way where it's harmful with pharmacodynamic drug interactions. It's all about having the knowledge of what these drugs target, what receptors, and what's the location of those receptors. And some more examples. I've provided you these specific examples of pharmacodynamic drug interactions in asthma, but we also have the combination of NSAIDs and SSRI. So NSAIDs are non-steroidal anti-inflammatory drugs used for when you have mild pain or fever or inflammation, like ibuprofen. And together with the serotonin or selective serotonin reuptake inhibitors, they may lead to gastric bleeding. And it's because SSRIs inhibit serotonin to plateaus. So that's one issue. Another one is in erectile dysfunction where patient gets sildenafil. What it does is that it inhibits phosphodiesterases that inactivate CGMP. And that would lead to potentiation of organic nitrates, so like nitric oxide. And nitric oxide is what causes relaxation of vessels, for instance. And that in itself, when we get a severe relaxation of vessels, it can lead to hypertension. So you have to be careful with what kind of drugs you combine with sildenafil. Any questions about pharmacodynamic drug interactions? If you do have questions, please pop them in the chat or feel free to use your microphone. So now to the pharmacokinetic drug-drug interaction, which is the bigger group of drug interactions that do happen. And just to remind me, I remind you, I said that this is ADME, absorption, distribution, metabolism, and excretion, the different processes that a drug goes through once we intake it. So interactions are most likely to happen if drugs are eliminated by hepatic metabolism. And the reason is, so in the lungs, not lungs, sorry, now I'm mixing up my organs, in the liver, we have the cytochrome P enzymes. It's a big group of enzymes responsible for metabolizing a lot of different drugs. And because they're responsible for metabolizing a lot of different drugs, if several drugs are dependent on those enzymes, there's going to be a competition. And therefore, it's going to affect the way one drug is metabolized over the other. And I will be providing you plenty of examples of when this happens. So let's start with absorption. Let's have a look at when absorption in pharmacokinetics can cause drug-to-drug interactions. So there are 4 different cases in which we can have 4 different types of examples of when absorption may alter the drug-to-drug interaction, or when the absorption of one drug will be altered by another. I think that's a better way of saying that. And one case would be when you deal with drugs that inhibit gastric emptying. So in opioids, I've mentioned tramadol before, but in other opioids as well, in treatment of moderate to severe pain, one of the main adverse effects of opioids is that they cause constipation. And the reason is that they slow down the contractions and movement of the bowel. And what that does is that it also slows down the drug absorption. Because it's not have a lot of movement, drugs are not moving through, and therefore drugs are not absorbed. So if a patient is taking opioids, there may be some drug-in-drug interaction. And let me please add that just because there is a likelihood for the drug interaction to happen doesn't mean that's always an issue. Sometimes that drug interaction, it will change the concentration a bit, but it's not an issue. So I don't want this to be where we are so afraid. Sometimes we have to combine the drugs, but the combination is better than the patient not getting the drugs. So that's one example when a drug can alter the absorption of another. Another is when you have drugs that accelerate gastric emptying, where they hurry that up. One example is with metoclopramide, is a dopamine 2 receptor antagonist, which has antiemetic effects. So it decreases the chances of nausea or vomiting. But because it does fasten the gastric emptying, it also means that it increases the time in which the drug is absorbed. So it has the opposite effect to what the opioids would do. The third case would be when you have drugs that interact physically or chemically with other drugs. So examples of that is when you ingest ions like calcium or, metals like calcium or iron. What they do is that they will form sometimes insoluble complexes with different drugs. One big example is tetracycline, a type of antibiotic. So you may have been on antibiotic and been told by your pharmacist or even the doctor saying that, please do not take this with milk or yogurt. It's because we have that calcium that can interact. Or if you've been iron deficient, as I am, and when I take my iron tablets, I have to take it on its own before I ingest anything, because there is a risk of those complexes being created. That also means that my body is not going to be able to absorb the iron. So that's also another risk. And that's why sometimes you will hear those recommendations, or maybe if you are becoming a pharmacist, give those recommendations out to yourself. And a fourth category is drugs that slow down local absorption. I think this one is a really interesting one. So I do teach into pain, which includes analgesia, but also into anesthesia. So this is a case where a pharmacokinetic interaction is utilized to increase the effect of the anesthetic. So with anesthetics, they can be locally injected. So it can be subcutaneously, for instance, like with lidocaine. And a lot of those preparations have a combination of lidocaine, but also adrenaline. And the reason they have the combination is that adrenaline will bind to alpha adrenal receptors in the vessels to cause the vessels to constrict. If the vessel constricts around the area where you're injecting the anesthesia, there will be a less surface or less chance for the local anesthetic to be absorbed by the vasculature, and therefore it will stay in its local fat or whatever you want to treat for longer in the muscle. It will have a longer duration because now the vessel is constricted, and therefore it's less likely for that vessel to take up the anesthesia. So that's one way of prolonging the effect of anesthesia. So that was about absorbance and how that can be utilized, but also how that can be harmful. So we've moved on to distribution-based drug-to-drug interactions. They can, most cases, deal with protein binding, and that is either albumin binding or tissue protein binding. So the way a lot of drugs are distributed is through by binding to different proteins. And if you have two drugs that are both dependent on binding to either albumin or any other tissue protein, there'll be a competition. And what that means is there's not going to be enough proteins to bind all the drug, which will result in a lot of drugs staying unbound. With a lot of drugs staying unbound, it means that they're going to be free. And whenever a drug is free, there's a risk that enzyme is going to break them down. So they are no longer protected. And maybe now you start thinking, all right, so if we have more free drug, that means that the concentration of the drug increases, but at the same time as they are more likely to be eliminated, the drug goes down. So it tends to actually not be an issue. So that competition on the protein tends to not cause too big of a problem, because the unbound drug, which would have caused them to increase in concentration because they're not bound and can therefore bind to the receptors, are now eliminated instead. So there's a balance between what is targeting its receptor, but also it's being broken down. So I do want to say that this doesn't tend to be a huge issue. There are exceptions though. So for instance, when we deal with antidysrhythmic drugs, so when you have an arrhythmia in the heart where the beat is not following the pacemaker or following a proper frequency. And one example is with verapamil, that will displace digoxin from tissue binding sites. So digoxin will bind to tissue binding proteins, and because verapamil does that, yes, you will have more free digoxin. However, verapamil also reduces renal excretion of digoxin. So it doesn't only affect distribution of it, it also affects the excretion, meaning that the concentration of digoxin goes up quite high, causing digoxin toxicity. So it's usually when it comes to protein binding, it's only drugs that affect both protein binding, but also the excretion of the drug that will have an effect. And with digoxin toxicity, that can include anorexia, nausea, vomiting, all kinds of neurological symptoms. It's very severe. But you can see that it did require that inhibition of renal excretion, and therefore an increase in the concentration. So now to the metabolism. So drug alteration can be caused by altered metabolism, and the main way it's done is either by enzyme induction or enzyme inhibition. With enzyme induction, what is meant is that you improve the ability of an enzyme to induce its effect. An enzyme is going to be capable of breaking down more drugs, or for instance, it can be that you increase the number of enzymes. So some drugs have the ability to do so. And inhibition is, of course, blocking enzymes, there's fewer enzymes. I'm just showing this table. It's a lot of information, but what this table is showing is the different enzymes. So there are much more CYP enzymes, but these are some of the most common ones involved in drug metabolism, and therefore also the cause of a lot of metabolizing interactions. And you'll see that there are different kind of drugs. So you have, for instance, ciprofloxacin and the different inducers. So these combinations will cause these drugs to change their effects. So you have inhibitors induces, so these inhibits, and you have everything from ciprofloxacin, fluconazole, bupropion, like that's a great amount of different drugs. But you also have grapefruit. And that's something you may be familiar with, how grapefruit should not be combined with a lot of drugs because it does inhibit CYP3A enzyme. I think it was especially CYP3A4, if I remember that correctly. And inhibiting that enzyme means that drugs that are dependent on that enzyme to get broken down will increase in concentration in the blood. So that's why the recommendation of not using grapefruit with some drugs is out there. And it's what I was talking about. We have inhibitors, but also inducers. I do want to point out that the drugs in bold are the ones where we know have quite of a strong inhibition of these cytochrome P enzymes. So with enzyme induction, and we are mostly talking about CYP enzymes, what it does is because we get more active enzymes, they tend to decrease the concentration of the drugs dependent on those enzymes. And there are various different examples. So for instance, these are some examples of drugs that will increase activity of enzymes. And these are some drugs that are affected. And oral contraceptives is very common one that does happen. So for instance, with St. Wort, it's a plant that is used over the counter to treat some depression and so on. That can remove the effectiveness of oral contraceptives. And of course, the adverse effect of that, if you didn't want to get pregnant, that would be the effect. So that's why patients who are oral contraceptives have to take care with some interactions with drugs. And this is some examples of different adverse effects or different issues that can occur from having enzyme induction. So for instance, if you have enzyme induction that is breaking down immunosuppressants, that's supposed to push down the immune system when someone has gotten a new kidney, for instance, then the body may start rejecting that kidney. So it can be quite severe. Or for instance, this is quite common. So when I did my PhD, I studied the cardiovascular effect of CBD, which is in the cannabis plant. It's not the compound that causes toxicity. It doesn't cause any high or anything like that. But that was one of those compounds that actually affected the concentrations of epilepsy medication. But that does happen quite often, that patients on epilepsy will have the treatment or the drug being broken down much faster because they are treated with another drug that induces the concentration. And of course, that means that they will have seizures, because that's one consequence. And I did mention this one, unwanted pregnancy due to loss of oral contraceptive effectiveness. And that's in combination with some anti-epilepsy medication, like carbamazepine, can happen. So those two are not recommended, especially with carbamazepine, because it is a long-term or chronic treatment. And you can see oral contraceptives to be semi-permanent, depending on how long you're going to be on them. But I also mentioned that we have drugs that inhibit enzymes, CYP enzymes. So these are some different ones that do inhibit them. I will be talking about this combination of drugs that is quite interesting. So in treatment of HIV, very often, or most mainly, it's protease inhibitors that are used. But protease inhibitors also tend to be potent CYP enzyme inhibitors. So let's remember, if you block the enzymes, what that means is that will increase the concentration of a drug dependent on that enzyme. Because now there's fewer enzymes that can break that down. And in the treatment of HIV, it's actually used as a benefit, where patients will receive something called a ritonavir boosted HIV regime. So ritonavir is a CYP3A4 inhibitor. So you have it here. And because it inhibits that enzyme, what it does is that it decreases the metabolism of HIV treatment. So that's one way of increasing the concentration of that HIV treatment or protease inhibitor in the patient without increasing the dose. By just adding something that would inhibit the enzyme, responsible for breaking down that HIV treatment, you suddenly will have a patient have a higher concentration of the HIV treatment, and therefore it will be more effective. But with that said, it needs to be well regulated because you don't want it to be too high either, so it causes a lot of adverse effects. But yeah, this is done on purpose. And something interesting and adds a little bit more complexity to it is that some of inhibitors can be stereoisomer selective, especially when it comes to CYP enzymes, where they will only inhibit one stereoisomer, and the warfarin, the R isomer, is the more active one, while the S isn't. This isn't super important, but it just adds another aspect to it that it can be quite complex. It doesn't just inhibit one particular molecule, it can be one over the other when you're dealing with isomers. So now we have excretion, which is the last part of the pharmacokinetics. And there are different ways in which excretion interaction can alter the drug effect. So for instance, it can be altering protein binding, which therefore alters the ability of a drug to be filtrated. So whether a drug is filtrated through the kidney or not is dependent on how it's bound. The kidney is very selective in the size of molecule that it excretes out with the urine. So that can affect the ability of a drug to leave the kidney. Another type is inhibited tubular secretion. One example of that is probenecid. And probenecid increases uric acid extraction. It's used to treat gout when there is an increase in uric acid. And because it excretes uric acid, it can also excrete other drugs, and that includes penicillin or pseudovidin. So it is taken with care, and it always have to consider that. So whenever you have a drug that increases the secretion of stuff like urine acid, there is a risk that it will also excrete drug. And if you get an excretion of the drugs, you have less of it in your blood. So you lose some of the effectiveness. Another example is when dealing with drugs that can alter urine flow or urine pH. So for instance, diuretics can increase urinary excretion of other drugs and metabolites, but usually I have to say that's not clinically important because it tends to be to quite of a low degree. But as always, we have some exceptions. So we have the loop and thiazide diuretics that are used in treatment of hypertension. And with those diuretics, what they do is that they excrete salt, so they excrete sodium. And as you get rid of sodium through osmosis, you also get rid of water. As the volume of the blood or the water in the body decreases, you also decrease blood pressure. However, imagine you have a patient with bipolar disorder that's taking lithium as a treatment. Lithium is an ion, so lithium plus. And what will happen is, as the patient is taking loop or thiazide diuretics that's getting rid of sodium, then kidneys naturally want to balance, so they're going to try to not get rid of as much lithium. So what happens is that the lithium concentration goes up in the body as the sodium concentration is going down, and that can lead to lithium toxicity. And that's very dangerous, especially when you're dealing with patients that already have other issues. I'm actually nearing quite the end. I know it's not a full hour, but I thought with mentioning all these different interactions, how do we reduce the risk of interactions? And as I mentioned, I didn't work as a pharmacist for long, but there are a couple of things that have improved, but these are a couple of things to think about. First of all, we need to get better at recognizing the drugs that are commonly inducing drug interactions. And as long as we have an idea, or quite a clear idea, what drugs have a narrow therapeutic index, it is very likely that those drugs are involved in drug interactions. So the anticoagulant warfarin, a blood thinner, very known for interacting with a lot of drugs. And same with a lot of anti-epileptics. So by having that knowledge, what that would mean is if a patient no matter what, if you're going to become a pharmacist or a doctor, whenever a patient subscribed, or if you're a pharmacist and you look at someone's drug list, if you see drugs with those narrow limited therapeutic indexes, that should get a red light to come up and to say, all right, what other drugs is this patient on, and do they interact? So one way of avoiding that is to keep track of the drugs with narrow therapeutic index. Another thing is to be aware of drugs that are dependent on CYP enzymes. With that said, there are a lot of drugs, if not most of them. However, some drugs are really strong inhibitors. So like the ones that are bolded here. And if we have an idea of which ones those are, then that can also have that, create that light in our heads to be like, all right, let's be cautious with this patient because they are on a drug that either heavily induces or inhibits CYP enzymes. And also, whenever a patient is introduced to a drug, we do say that all over and over again, we need to know what other medications are on. There's no other way, and that's where pharmacologists or pharmacists come in. I think pharmacists do not get enough credit for their pharmacological knowledge, because with pharmacists, if hospitals did have more pharmacists in there going on rounds with the doctors, I really believe it would reduce the likelihood of patients coming back because of adverse effects due to drug interactions. So by inputting a new drug, it would be amazing for doctors and pharmacists to work together to look into, is there a risk for drug interaction? But not only that, because very often when a patient has been on two drugs that do interact, it will change the plasma levels, but also the effectiveness of one drug. So for instance, let's say a patient is on a drug, let's say SSRI, for anxiety or depression, and it's not working at the low dose because maybe they have another drug that's interacting with it. And the doctor may not even know this. So we tend to up the dosage, so it's higher, until we see, all right, this is actually really effective. Imagine if the patient stopped with the drug that was interacting with it. Suddenly the patient will have a drug dose that's way too high, and that will lead to adverse effect. So we need to take care both when a drug is introduced, but also when it's stopped. And it should be part of a routine care to monitor a patient for drug toxicity, but also for loss of efficacy. When a drug stops working, and with that said, it's very difficult to tell in some cases. So with oral contraceptives, if a patient, you don't know if a contraceptive is working unless someone gets pregnant, and that's not good enough. So we just need to make sure there's no interactions. And there are some resources. I'm actually quite curious to hear how it is in Indonesia, but I know when I worked as a pharmacist in Sweden, there was a software. So whenever a patient would come in, we would take the ID of them, scan them through, and we could see the drug list, what drugs they have. And there was a system that would give us a warning signal if there were drugs that are known to interact with each other. So because it's a lot of drugs to keep track of. Imagine knowing all the interactions. We don't. We know the most common ones. But yeah, I'm actually quite curious to know what the system is like where you live, if you have that kind of system, or because that would be interesting. But that is something that's happening, but also it's a lot of websites. With different food and drug administrations. I know there's one in Australia as well. So I'll stop there and I'll say thank you so much. And let me just stop sharing. I'm happy to answer any questions that you may have. It can be small, but I'm happy to hear about your experience.
Hey,
Okay.
Yeah. Okay. Good morning, Miss Anna.
Hi.
Okay. First, I want to introduce myself first. Okay. My name is Salza Devinta, and I'm 17 years old, and I am currently in the second year of medical school. So I am sorry if maybe I have lack of experience or knowledge. So
No need to be sorry.
Okay, thank you so much. And I just want to share my experience. It's about pharmacology also. So I think that this is a good opportunity because I can speak immediately to the expert. Okay, so I actually got conjunctivitis like 3 months ago. And I was thinking that maybe it was because of viral or because bacteria. And I tried to use antibiotics and I used amoxicillin at that time. But I use it just that. And I use like the eye drops, eye drops. And it didn't comes in a good thing. Like it lasts for 2 weeks. Like I was thinking, why this medication doesn't work? I was thinking like that. But then I tried to combine with corticosteroid like dexamethasone. Yeah, and then actually it comes in a better way, like and at that time I was
was it eye drops? Was it local
Yeah.
administration?
Yeah, I tried the new eye drops. Like it contains also dexamethasone at that eye drops, and it finally comes out with a good or better result. Like I was surprised. Oh, this is the thing that I learned in school, and then I experienced the result by myself. Like wow, this knowledge is so important. At that time, I still at the first semester in in the second semester in medical school, and I already feel the benefit from this knowledge of pharmacology. And I just want to share that experience to you, like, yeah, because I think it was amazing thing to be able to doing my own research in some journals, and then I tried to use the drugs, and I experienced like the combination of these drugs can make the better result for myself and my health. It was so beneficial. Yeah. And right now in Indonesia,
Mungkin bisa dipersingkat, Dek.
yeah. So I want to ask a question, Miss. There is a case in Indonesia that is acute kidney injury. Do you know about that?
Yeah.
So yeah. Okay, so it is maybe because of the pharmacology reaction of the drugs, but maybe you can search on Google or something. So right now it is become the trending topic in Indonesia. It's about acute kidney injury. So I want to know your your comments about it, Miss. So because I think that you're expert in this knowledge. So thank you.
No worries. I'll look into that. But to be honest, I don't know.
Maybe
My
I can
knowledge of kidney is very limited.
maybe I can explain about a little
Yeah.
about the case happen now. So in Indonesia, I think there is either the excipients itself, it's kind of like making what's it kind have like a high amount of the excipients. Either it's because of the contaminants or it's there at the same time in the syrup. So it's the excipients for the diluent, and it happens to injure the kidney in the children. Yeah, so now it's happening. So right now how it's called, like the FDA in here is kind of still trying to find what's happening right now, what is really the cause and stuff.
I'm quite. So is this a locally produced drug or is it something else? Like, what is this drug for? Do you know?
Right now, the drug that has been looking at is the paracetamol syrup. Syrup.
Wow.
Yeah, so
okay.
it's like many brand of it. So the FDA in here is trying to find out what's happening.
That sounds horrible, especially with kids. Yeah.
So yeah, maybe like Salza said, if you have like an opinion in here, some things maybe, because I think most of it actually the problem, I'm not sure, but I think it's like the excipients itself, not really the drug itself.
The thing with excipients, so especially, with the pandemic, can I ask in Indonesia, sorry for my lack of knowledge, did everyone get vaccinated in Indonesia for the COVID virus?
I think most of us have got it.
Perfect, because so there was a lot of talk, so this is going into conspiracies where people think that the excipients in vaccines are really harmful. And one thing to know about excipients, very often, it's mostly just lactose. So something that is found in milk. So it tends to not be dangerous. So it'll be interesting to read about that case. I'm quite curious to know what's I guess in an oral solution of paracetamol, there
Yeah.
may be other kind of excipients in it.
I think the excipients that is being seen now is ethylene glycol.
Yep.
Yep.
Yep. And especially in solutions. Yeah, I see. Oh, that's interesting. And yeah, I'm sorry to hear that. It's horrible.
Nice. Yes. Okay, so yeah, maybe another questions. Oh, yes.
I
You can
see,
go.
yeah,
You can go. If it's possible, can you open your camera, Raka?
Well, I
Hi,
can't really,
Raka.
yes, good day.
Hi.
I can't really disassemble my laptop to open the camera right now, but I can turn it on like this. Anyways, I think I'll just get to the questions. So firstly, I just found that I was reading a little bit about mycology, especially relating to fungal infections, and
Yes.
they included this handle tab for the prescription of drugs. I'd like to know more about the systemic drugs because if I remember correctly, I read, yes, for fluconazole, we can treat the patient with fluconazole in about a week, but for the first day, there are cases where you have to double the dosage. So say we have a 100 milligram dosage for the overall for the tablets. During the first day, you have to give 200 milligrams. Is there any particular reason? Is that to see the sort of toxic reactions of the drug or see how the patients respond to it? And that's probably the first question. So, but for fluconazole especially. And the second one would be about the SSRI, the serotonin syndrome, something inhibitor.
Selective serotonin reuptake inhibitors. Yeah.
Yes. Do they have to be included for, say, drugs that treat neuropathic injuries? And what is the toxic reaction of the drug? And what is the effect that will happen if you don't give them the SSRI drug?
Okay, I'm going to try to, just to make sure I respond to you correctly, I'm going to try to repeat what you said, and you can correct me if I'm wrong. So you were asking about fluconazole, and was it about why the dose is doubled to begin with before?
Yes.
So honestly, I don't really know, because so with me being a pharmacist, it was quite of a short time. So now with pharmacology, I understand the pharmacodynamics, but not necessarily the treatments. I can tell you this, that with some drugs, especially let's say you have an infection and you want the drug to reach a certain plasma concentration quite quickly, what does happen sometimes is that the dose is quite high in the beginning to make sure that the patient reaches a steady state concentration faster. So I don't know if you remember Tmax, the time it takes for a drug to reach its maximum concentration, that will happen faster if the dose in the first days are higher. However, you don't tend to do that. You tend to do the opposite with many other drugs, where you slowly go up to acclimate the patient. But with cases where it's an infection, I can see them wanting to go in quickly. But I'm not sure someone else will better have the response to that. And with the SSRI, the selective serotonin reuptake inhibitor, were you asking whether it's needed? Was that in pain? Is that what you were referring to, or?
Yes. I was searching it up for a bit, and maybe can it be prescribed in, say, neuropathic conditions?
I see, neuropathic pain. Okay, yes, a great question. So actually, SSRI is not very often used in neuropathic pain. What is used in neuropathic pain is older antidepressant drugs, like tricyclic antidepressants are more commonly used in treating neuropathic pain. But not only that, in neuropathic pain, so usually with opioids, you don't want to use them for too long because there is a risk of dependence. So when someone has nerve damage that causes that pain, they will either go to old-fashioned antidepressant, tricyclic antidepressant, or to anti-epileptics like gabapentin. So to my knowledge, it's not very often a patient will receive SSRI for the treatment of neuropathic pain.
So the alternative would be to use the suppressant slash the what is anything that reduces neurological activity.
Yes,
Right.
exactly. Yeah, you're spot on. And with the anti-epileptic medication, it is believed it's because it induces GABA and causes therefore a slowing in the communication between neurons. But it's not fully understood still in pain. In pain, we don't still understand why tricyclic antidepressants work. We just know that patients are in pain, and if that's what works, great.
Thank you. I think I'll end the question there. Thank you very much for the answer.
Oh, no worries. Great questions. Thank you.
Thank you, Raka, for your questions. Maybe another question from the audience?
And it's nice to know what I'm lacking in knowledge. There's so many things I want to look up after this.
Yeah, no, it's okay. For the fluconazole, I think it's right about like loading those stuff. So yes, is there any questions? Okay, maybe this is just out of my curiosity, because we know that like cytochrome 450 is usually have like a lot of stuff, and you know there's like a genetic, like the slow inducer,
Yes.
the faster inducer. Do they like in Australia use doing some like genetic tests to prevent this or something like that?
It's not there yet. It's not part of general practice, but there are a lot of discussions about it. Are you familiar with personalized medicine? It's becoming a big thing everywhere in the world, where the idea that we need to start personalizing medicine. And we live in a world with a lot of different ethnicities. A lot of studies that's been performed thus far has been, let's be honest, in white men. And I think we've come to the realization we are not all white men. So it's moving away from that, where we do have personalized medication, but it's not there yet here. I think it's way too expensive to begin with, and we don't have a clear understanding. Yeah, but it's getting there.
Okay, thank you very much. Maybe another question. Someone open the mic.
I can see someone speaking, but they're on mute. Is it Maria?
Yes, you can go, Marilla.
Okay, I want to ask a question, but before, thank you, Dr. Mazeh, for the explanation information. And maybe I want to ask something that we know that right now there's a lot of drugs has been found until today, and I believe that each drug have specific interaction to each other. So I want to ask something. What is the best study or some kind of what is the best study to understand its drug interaction, because there is a really lot amounts of drugs, and
yes,
in Indonesia we often prescribing a patient more than 5 drugs maybe, especially in geriatric. So what is the best study to check on it?
So I will just quickly, I've just sent a link on the chat. This is just one of the websites. So there are a lot of websites. I can actually, sorry, I'm not going to take too much time. I can just share quickly my screen. Can you see that I have a internet website?
Yes, perfect.
Yes. So this is one example. There's so many of these websites out there. Please have a look and make sure that it's one that is supported by the FDA or so on. But for instance, in this one, you can write different, like omeprazole as one drug, and then let's say fluoxetine, which is an SSRI. And it will tell you if there's any interactions. So in this case, I put 2 active substances. It says 1 interaction exists. And it says fluoxetine will increase the level or effect of omeprazole by altering drug metabolism. And hopefully after this lecture, you'll think, all right, they're probably interacting by CYP enzymes. But it also says that interaction is unlikely or minor or non-significant. So there are different resources, but so because I was a pharmacist in Sweden, I know the Swedish resources, and you can imagine Swedish is very difficult to learn unless you speak Swedish. So I can't recommend any of those, but have a look. There are resources for people, practitioners or pharmacists where you can input drugs and they become really good.
Okay, thank you, Doctor.
No worries.
Okay, thank you for your information. It's very clear.
Okay, thank you, Marilla. Maybe another questions?
This Christopher, is it? Christopher?
Yeah, Christopher, you can go first.
Thank you for the time. I'm very nervous. I'm sorry.
That's fine.
I'm not used to talk in English, so
That's okay. Go, take your
I
time.
have a
English is not my
question.
first language either.
I have a question about pharmacology with perhaps in the effect of pharmacology in the future of maybe like, is it possible for a drug to affect the metabolism of the human permanently, like maybe change the DNA? I mean not the DNA. I mean like how the cell metabolism works. So the drug makes the cell permanently immune to like maybe an infection or something, or is it possible that the change happened to the cell became permanent and the person or the human consume the drugs may not consume the other drugs since he has or he or she has already consumed the or first drug. I'm sorry.
Yeah, no, great question.
nervous.
No, you should never be sorry. You should just be proud that you speak several languages. It's amazing. And I got your question, whether a drug is capable of causing its inhibition of an enzyme, for instance, or a receptor if it's permanent. And absolutely. So you may be familiar with aspirin or acetylsalicylic acid. That's one of them.
Yeah.
So it inhibits platelet function, and that's permanent. However, because of that, so just because something have an effect on an enzyme or whatever that might be permanently, doesn't mean that you can't produce more or that there is a breakdown on whatever is being changed. So for instance, when I was talking about asthma treatment and that fact that it increases the affinity of beta-2 adrenal receptors, some receptors break down eventually and get recycled and you get new receptors. And also in drug discovery, very often we don't want to have drugs that have permanent effects. Because if we're dealing with a drug that, for instance, have a really high affinity, or it's a non-competitive antagonist, and it binds to its receptor and stays there, if we were to dose a patient at the wrong dose, and if we can't reverse that, that would be catastrophical.
Yes,
So we tend to, mainly in drug discovery, what they do is that they work with drugs that can be reversed. So for instance, with opioid toxicity, there is naloxone and an antagonist of the mu receptor. So we can reverse the effect of overdose with heroin or morphine. So a lot of drugs we tend to not go there. So there's few drugs that have permanent effects because that would be very harmful for patients. If we can't reverse it, we get to high a dose.
Oh, yeah. Thank you. Maybe I
No
have
worries.
one more question also about the effect of drugs. Is it possible that if someone take a vaccine and since the vaccine like change the how, I mean like the immune system of the person, is it possible that certain vaccine could make the person receive the vaccine unable to take some kind of drugs?
With vaccines, something that we sometimes forget about vaccines is that a vaccine is a means of treating a patient. So a vaccine is inducing an immune response at really low doses of a drug. But all vaccines are so different. So talking about vaccines as a group, as them causing something particular, it's very difficult. It's not like talking about SSRIs, because SSRIs is dealing with one particular mechanism of action. With vaccines, they induce different kind of immunity. So I really can't respond on behalf of vaccines as a group because they're also different. And honestly, it's not my expertise. I don't know a lot about the effects of the different vaccines because it's not something as a pharmacist that I would prescribe to a patient or give to a patient.
Hey, All right, thank you, Doctor.
Great question. So yeah, thanks.
Thank you, Christopher, for your questions. Is there any other questions? Oh, okay. Before to Salza, there's a question in the chat asking about but it kind of drug interaction. It's a drug protein interaction, if that's okay.
A drug what?
Drug protein interactions.
I'll try.
So if we modify the structure conformation of ligand protein in silico, does it will change the drug protein interaction? And if it does or not, how does it change the pharmacodynamics or pharmacokinetic of it?
Could you please repeat the question? So if we change the
if we change the structure conformation of ligand protein target in silico, does it change the drug protein interaction, and how it does affect the pharmacokinetic or the pharmacodynamic of it?
Of course it would. So if you change the conformation, because the ligand and protein are very specific, we always use the analogy of log and key. However, what I don't understand with the target, because the targets are in vivo in our bodies, I can't imagine that we very often would take out the target, change it, and then put it back. So I don't know what kind of clinical significance that plays.
Okay.
But if we were to do that, then of course it would change it, because yeah, it's a ligand and a protein has a very specific binding. That's why it's difficult to create drugs that's specific to one subtype of receptor, but not the rest.
Okay. So is there any like research of this happening right now or something like that?
I am not aware of, I'm not aware of that.
Okay. Thank you very much.
Maybe I don't know enough about it.
Okay. Thank you very much. Maybe there's another questions. Someone who raised hand, maybe? Someone who opened the camera, maybe? Okay. Salza?
Okay, thank you so much for the.
Can you, before
Sandy?
you question,
Yeah?
can you open your camera first?
I'm sorry because the signal is not too good. Okay, so I'm sorry. Maybe this question is a little bit out of topic, but can I ask this question? But it's also about medicine.
Of course, you can, of course. And I will be honest, if I don't know it, I won't answer it. I'll say,
Okay, thank you so
absolutely.
much. Yeah, so I want to ask a question that, is it possible for us, Indonesian medical graduate, to practicing medicine in the Australia? So actually, I have an interest to practicing medicine abroad as an international medical graduate. So is it possible for us to become a doctor in Australia while we are graduating not from the medical school in Australia? And maybe do you in Australia provides like scholarship or something, or maybe in the University of Melbourne provides scholarship for us, or what kind of facilities that the University of Melbourne provides for us to do that? Thank you.
Great question. And also, I really encourage, if we do have the opportunity to do stuff abroad, to do it, but I also understand that it requires a financial means. So when I studied abroad, so in Sweden, we don't pay for university, so I never really paid for it. So regarding med school or being able to practice in Australia, I think, as far as I know, I don't think there are any scholarships. However, if you do finish your education, of course, you can come to Australia to practice as a doctor or whatever you want to practice as, but you may have to take on some, either go on grounds or do some internships in some cases. But I'm not really familiar because I only did my PhD in Australia and I'm not from here. I'm not very familiar with the system itself, but I really encourage you to look into that. And if that's a dream of yours,
Yeah, you're right.
Yeah.
Yeah, because as far as I know that in United States, they provide like USMLE tests if there is an international graduate student that wants to pursue their career in the United States. So maybe Australia also do that.
Check it out and talk to you in Melbourne.
Okay. Thank you so much for your explanation.
No worries.
Thank you very much, Dr. Mazeh. Maybe one last question, if there's any one last questions. Just for your information, now we have like 165 participants.
Oh, wow.
Is there any
No
other
pressure.
questions? Okay, I think everyone now already understands about the pharmacokinetic and pharmacodynamic of drug interaction.
Good luck with your pharmacology studies. I think it's I mean, the best topic in the world. Of course, I'm very biased. Pharmacology is amazing, and yeah.
It is. So like I will like to maybe like conclude a bit of what have you talking like for the drug interaction, it can be harmful, but at the same time it also has the beneficial of it. So what we can do is just like understanding more deeply about how the drug work, how the target, how the receptor and everything. So that's we can know how to use the drug properly. And also like we have, if we want to reduce it, we have to recognize, and the most important, like working together between the pharmacist and the doctor, because hopefully in the future, all of the audience is the doctor in the futures. So working together to monitor the patient, monitor the toxicity, and also the efficacy of the drug itself.
Yes, and it's all about knowledge, but also, like we know, if you've done research, the research changes. So being up to, there's a lot of subscriptions that you can do in current research in medicine. And that's a good way of doing it, where you get weekly emails or where you search information, because things change. And I guess with being a doctor, a researcher, a pharmacist, pharmacologist, you're always seeking new information. So I think that's the key.
Yes, keep updating.
Yeah.
So yeah, so thank you very much again, Dr. Mazeh,
Thank
for
you.
all of your knowledge, for answering all of the question in here. We are really grateful to have you here.
No, thank you.
And it's really nice having you here. And before I close, I will give back the mic to Alia. So Alia, the mic is yours.
Okay, thank you. That was an interesting topic to learn. Thank you once again for our speaker, Dr. Amna Mazeh, for sharing her knowledge with us. Ladies and gentlemen, we kindly ask all participants in today's Zoom room to turn on the camera for a virtual photo session. So please kindly turn your camera on. Okay, we're gonna start from page 1. One, two, three. Okay, we will wait for a second. Okay, we're gonna start from page 1. Thank you. Next to page 2. Okay, thank you. Finally, we are in the end of this event. Once again, I would like to express our gratitude for our wonderful speaker today, Dr. Amna Mazeh. Thank you.
Thank you so much, and good luck with everything. Bye,
Okay.
take care.
Also, thank you for all participants in both Zoom and YouTube for your enthusiasm today. We hope to see you again in our next event. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you.
Untuk yang masih ada di Zoom, ada link sertifikat, silahkan untuk diakses. Kemudian kalau teman-temannya tadi sudah ada pada keluar, bisa di-share ya, Dek, ke teman-temannya yang lain. Terima kasih.
not even half as pretty. You gave her your sweater, it's just polyester, but you like her better. Wish I were.
Sudah tak bisa melewati lagu? Dengan premium, kamu bebas melewati lagu yang tak mau didengarkan dimanapun itu. Jadi, saat kamu mencari lagu yang sesuai suasana hati, kamu tak perlu menunggu untuk bisa melewati lagu lagi. Masuki dunia premium dan dengarkan yang kamu mau kapanpun kamu mau.